Good afternoon, everyone. Thank you for joining us today. My topic is breast AI and mostly clinical applications. It's an introduction, but it's going to be an introduction to what I feel are the hot topics in breast AI at the moment, things that I'm dealing with quite a bit. And I thought that that would be a good window into what the hot topics are right now with breast AI. First of all, this is something I've been using for 4 years now in terms of detection. I've been using image-based risk assessment, AI algorithms, for about 2 years. I've done research in both areas, mostly validation type studies, looking to see exactly what the strengths and weaknesses were in terms of performance, how K-scores distribute and things like that. And so for me, this is not theoretical. This is not the future. It's my day-to-day and has been for a number of years. At this point in time, given my experience, there is really no way I would go into any type of practice if I didn't have this type of support, meaning AI support with my day-to-day. Next slide, please. I have a ongoing consultant and stockholder consulting relationship with iCAD Medical. They are the source for Profound AI software suite, and that's mostly what we're going to review here because it really touches on all the key points for how people are using breast AI at this point. I've learned from talking to multiple groups across the country that are looking at getting into AI and or who have AI and are trying to get up to speed. I've learned that the algorithm itself is very, very sound, and it's no surprise that AI algorithms can find breast cancer. That's totally in their wheelhouse. Pretty much every study that has looked at this has come up with the same conclusion. So it's pretty much, in my mind, universally accepted that these algorithms are very good at detecting cancers. What I have learned also is individual users, in my case, breast radiologists, often aren't sure exactly how to use the technology. So mostly from my point of view, when I've seen rollouts at a clinical site not progressing as fast as everybody would like, it's in my view a lot more to do with the user's understanding of the algorithm and knowing how to use it rather than it is the performance of the algorithm itself. So the algorithm is one thing, understanding it and being able to use it is another, and that takes a lot of that takes some time and work so the user knows how to use these algorithms. And that to me is almost as interesting as the algorithms themselves. So you know, telling people what to look for is definitely part of the process. Getting up to speed really requires you develop a trust for the algorithm. Just like in any relationship, if you want it to work, if you want the advantages, then you have to trust your partner. And for me, reading breast, the partner I have every day is the algorithm, and I trust it, and I get the benefits that I had hoped for. First topic I want to hit is image-based risk assessment, and we're going to talk about cancer detection and density. We're not going to talk about report formatting as an AI function, but I wanted to hit on the breast image-based risk assessment first because it's really a hot topic for me. And let's go back to the last slide just for one quick second, just so I can put it in a little context. So here we are, you know, and I wanted to point out density here because it took a long time for that to happen. We knew for a long time that the high density interfered with our ability to read a mammogram, and we finally realized that there's an increased risk, but it took a lot of patient advocacy and work to get this in routine practice. We're facing a similar challenge now with the image-based risk assessment algorithms. There are some definite similarities between the two. So, we have this functionality now, and the challenge is to get it out there, get it accepted, and get it protocoled. Next slide, please. Again, we're using models now that are decades old. They're based on family and medical histories. They're based on patient input. ACR has come out with recent recommendations for risk assessment for all women earlier in their lives, around age 30. And these old models, frankly, don't perform very well. Accuracy 56 to 63%. Now, in terms of an AUC curve, that's a little better than flipping a coin, but not much better. So now what we've seen from multiple sources, development of algorithms that can compare the two sides, left and right, for asymmetries, calcifications, distortions, et cetera, and come up with a number, a measurement, if you will, that indicates the patient's risk of developing breast cancer in the short term. So we're talking a 1 to 2 year risk versus lifetime risk, which is typically what you see with the traditional Tyler-Cuzick type risk assessment models. So accuracy with the 3D DBT, 3D mammogram, 80% for these models versus 56 to 63% for what we've traditionally been used. And why is this important? Because again, going back to density, we need to advocate for this because we've got a model here that works better than what we've been using, but it's just not been out there long enough for people to understand it, and more importantly, for insurance companies to pay for it. But let's go to the next slide, and I'll show you some performance differences here. And again, this is an actionable risk score relatively compared to what we've been doing. And by that, I'm talking 1 to 2 year risk. So you can see AUC here. This is the performance, a significant increase. And again, this applies to the ICAD algorithm, but there are other sources, and they're coming up with similar findings. Just like with detection, I am not surprised by any of this, honestly. So it's real, and I've been using it. We've been looking preliminarily at the change in the image-based risk score over time. That's something that's just evolving now. Most of the papers that we've seen up to date have been looking at one point in time in terms of a case score or a lesion score, or in this case, an image-based risk score. And what we're seeing is that those measurements are dynamic and they change over time. So another big advantage of this type of risk assessment is you remeasure every time the patient comes in. Tyler-Cuzick, when you have patient input challenges with this algorithm, there's no patient input required. The score is calculated from the images that you already have, so there's no FTE needed to put the patient history in to come up with a risk score. Patient really doesn't have to get involved other than supplying her mammogram, which in essence is kind of a biomarker for where they're at. Now, this is, we compare the two sides. We look for early distortions, most likely. This is a black box in regards to exactly what is being detected. But the main theory here is that prior to the visualization of a morphologically recognizing malignancy, which is what we've all been trained to look at, there most likely are significant macro environment changes in the parenchyma around that area in response to the body's attempt to fight the malignancy, types of inflammatory processes that can result in distortion of normal anatomy that makes it asymmetric and visible to the algorithm when comparing to the opposite side. So if you start to see these changes in the parenchyma prior to something we can recognize, then most likely this is the source of the high risk score. But in any regard, not knowing exactly what is being defined, it does, in my experience, offer some amazing warnings that trouble is on the horizon and these patients need to be followed more carefully. The list of what you can do isn't that long, ultrasound, MRI, genetics potentially, but I would recommend that you look for some of the articles. I have a link at the end of the talk that connects you with some of the articles. Most of this work for ICAD came out of Karolinska Institute in Sweden, which is a massive epidemiology center, and their numbers were based on tens of thousands of mammograms, mostly 2D, mostly white population, but it laid a foundation for subsequent articles that also came out and confirmed the same. Next slide, please. So I'll come back to risk again because it's something obviously I'm advocating a lot for. I've been using it. I think if you adhere to the scientific papers, it's definitely superior to what we've been doing. So the meat and potatoes, cancer detection, 8% in improvement in sensitivity, less recall, reduced reading times. That's variable. That's going to depend obviously on the user, but next slide. Again, every paper out there pretty much shows that AI has the capacity to detect cancer. And we've found that the studies of users, there was a recent paper from Boca Raton, and they're seeing about a 10 to 15% increase in their detection. That's kind of similar to what I've seen. My AUC or my MQSA numbers definitely showed improvement when I started using this. What happens here, it compares sides and it will mark the cancer. You can see here at the bottom of the image, there's a circle drawn around the malignancy and there's a case score. So you get a numerical score for the possible cancer and you get a numerical score for the study overall. And those scores are a reflection of the algorithm's confidence that there is malignancy. You can go to the next slide. So what we end up talking with new users about a lot is how to use these scores. It's something new for most readers to have these scores popping up and trying to figure out how to use them. And we've done some analysis and tried to break these scores down. And for the most part, what you'll see is very low scores occupy by far and away where most of the detections are. You would expect around half or maybe slightly less than half of the mammograms not to have any detection at all, which is a huge difference from the old CAD that really kind of polluted the waters on CAD for some people. What we had 10 years ago is nothing like this. So when you do get a detection, again, that happens about half the time, maybe a little less. Then most of those detections and scores are going to be very low, as is consistent with what your population is. And so those are very actionable, almost autonomous. Your high scores, those are where the cancers are, but there are also mimics in that group that you need to pull out, such as atherosclerotic calcifications or post-biopsy scarring. The algorithm typically is not going to be able to distinguish a post-biopsy scar from an invasive malignancy. And then the middle scores are, those scores are more for the radiologist still to figure out. So it's a binary decision here you're trying to make when you look at a screening mammogram. Do I bring them back or do I send them home? And actually, if the scores on the algorithm are very low, then the algorithm is pretty confident that it's not a malignancy. If they're very high, it's pretty confident it is a malignancy after you take out the mimic lesions. In the intermediate scores, the algorithm's not that confident one way or another. So in terms of autonomy, the most autonomous scores, and I'm not recommending anybody read these without looking at them at this point, but for the most part, the algorithm can do most of the work on the low scores. Those are pretty much all going to be negative. The high scores are going to need radiology input at a higher level, and the intermediate scores need the most radiology input to sort through. But again, next slide. When you're dealing with your day-to-day, And the fact that 10 to 30% of cancers are missed, let's say not recognized, it's huge to have the algorithm running beside you as a double reader to keep you from missing things. And honestly, I love that my cancer detection rate's gone up. I love that my recall rate's gone down. But I really, really like that at the end of the day, my stress level is much less because I've had everything double read at the time. And I'm just not that worried I'm going to miss a 5-6 millimeter little invasive cancer anymore, because for the most part, the algorithm is going to draw a circle around it and present it to me on a silver platter and let me look for other things that might be on the image. So it is an extremely helpful clinical tool. In my opinion, it is something I use every day. And again, the decreased stress, for me personally, I've been doing this for 35 years, is huge. And if you're just looking to go into mammography, if you're in training, this is going to be a huge impact on your lifestyle going forward. And I would strongly encourage you to press your group to adopt some type of AI. The last functionality that I'm going to touch on is density. Next slide. And this has become a much bigger deal in the past 10 years. And the problem here is you can look at an image and guess the density, and the person behind you can come in with a completely different version. So I strongly believe that automated density measurements are the way to go, at least for consistency. So next slide. So again, I just wanted to touch on this one more time, because I think in the risk assessment area, you're going to see a disruption big time with these algorithms. And so I'm an advocate for this technology. I really encourage pretty much anybody I come in contact with to at least look at it and give it a try, because for the younger people listening in, this is your future, and these algorithms are super solid, but it takes some work on your part to understand them. And also, there's existing biases about this type of thing that need to be addressed also. Next slide. So just this is the type of scorecard you get with the iCAD product. It's a suite where you get K-score on the top, which is the overall chance that the patient has cancer. You get the density, and then you get the risk score on the bottom. And without even looking at the mammograms on this patient, I can tell you right now that this patient, has a high risk of having an underlying malignancy. The risk score is 1 to 2 year, is a 1 year risk for DBT. But it is another metric, and like I alluded to, what we've been seeing, interestingly, is if this risk score, that's the bottom where it says high, and it gives you an absolute and a relative risk. If that score was in the general category a year ago and now it's high, it's looking like that might be a very, very strong predictor that the patient is possibly already has or is going to experience an imminent cancer diagnosis. The neat thing about this is, you're measuring a change in the breast parenchyma that may or may not be visible, but is an indicator that something's going on. So that's an insight that we've never really had before. Next slide. So I truly, truly believe, with 35 years experience, that women deserve better than a single human reading the mammogram. In that regard, and I make that statement because in the right hands, if you understand how to use this, you're going to do a better job. And when you combine all the metrics here, the risk detection and the density, the expectation would be better outcomes. You've got an actionable risk algorithm. You've got less likelihood to have missed cancers, and a consistent density measurement that's actionable. Next slide. So here's a link, QR code to my site, and I have content on there along this topic. We're going to be updating some new things in regards to what we've been seeing with our delta risk research, which I alluded to, reflects the change in risk scores over time. And then there's links to the initial risk image-based risk algorithms that came out of Karolinska Institute. So I really appreciate all your attention. I feel very strongly that this is the future for radiology. Mammography has always been at the front end of this development, in part because the anatomy is much more straightforward than, say, chest or brain. And also, you're asking yourself with screeners a binary question of whether you bring the patient back or let them go. And this is totally in the wheelhouse for what AI can do, and for the people in training. This will be your future. This will give you a better lifestyle, and this will help you do, perform better in your day-to-day cancer detection. So thank you so much, Dr. Pershik. Jordan, thank you, and I look forward to hearing back from the audience.